Good afternoon, one and all. My presentation is on monotherapy with tacrolimus, 0.03% ointment in vernal keratoconjunctivitis in pediatric patients. So it's known that steroids constitute the mainstay of treatment in VKC, but is deemed to be a risk factor for many associated complications. So the purpose of the study was to evaluate the efficacy and safety of monotherapy with topical tacrolimus, 0.03% ointment in the treatment of VKC in the pediatric population in a tertiary eye care center in South India. This was a prospective non-randomized observational study. Children in the 5 to 15 years age group attending the pediatric clinic of Aravind Eye Hospital, Tirunelveli, Tamil Nadu were recruited for the study over a period of 8 months. Sample size 45 subjects. The persons who were included were new and previously untreated cases diagnosed as VKC, cases of VKC refractory to conventional anti-allergic therapy, cases in which there was a relapse after withdrawal of steroids, and cases which had developed steroid-related complications. Exclusion were history of contact lens usage, coexisting ocular infections, past history of ocular surgery, herpetic eye disease, and known hypersensitivity to tacrolimus. All the recruits were subjected to estimation of best-corrected visual acuity and intraocular pressure estimation by non-contact tonometry, followed by a thorough slit lamp examination for grading the disease as mild, moderate, and severe, for which we had formulated a clinical scoring method from previously published studies. So these were the 6 symptoms which we had considered, and these symptoms were graded on a scale of 0 to 3 plus. Composite symptom scoring was done, and at each visit, this composite scoring was used to assess the subjective improvement with treatment over the study period. This is followed by scoring of composite. We also formulated a composite clinical scoring system. These were the 6 signs which we considered, and the composite sign scoring was used to grade the disease as mild, moderate, and severe. Accordingly, we formulated a dosage schedule by which severe disease was treated with tacrolimus 0.03% ointment BD for 2 months, HS for 2 months, and alternate day for 1 month. Moderate disease was treated with BD dosage for 1 month and HS for 2 months, and mild disease was treated with HS dosage for 2 months. Patients were followed up at 2 weeks, 1 month, 3 months, and at 8 months. In case of bilateral disease, the eye with more sign score at initial presentation was taken for grading and statistical analysis, though the treatment protocol followed was the same for both the eyes. The primary efficacy endpoint was the change in the composite sign score. Failure was defined as additional requirement of topical steroids in the first month, and safety was based on the incidence of adverse events. The changes in the clinical score from the baseline visit and each follow-up visits were compared by paired t-test and Wilcoxon sign rank test. P-value less than 0.05 was considered significant, and all analysis were performed by Stata 11.1 Texas. The results came out like this. 88.9% of patients showed significant clinical improvement, and 11.1% turned out to be treatment failures. Treatment failure was noted in 4 subjects who had to be started on steroids within the first month of starting tacrolimus therapy. No adverse event was noted. And this is a graph showing a comparison of composite symptom score and sign score over the entire study duration. The graph, both symptom score as well as the sign score, shows a steady decline from the baseline visit to the visit at the 8th month. This is a quick rush through the review of literature. Chatterjee et al. Has done a study on 30 patients with steroid refractory VKC with the same strength of tacrolimus over 12 weeks, and they have showed successful outcome in successful clinical improvement. However, it was not a monotherapy, and they had used ketotifen and lubricants in addition, and the population included was not pediatric patients alone. The second study, Kimnios et al., he had tried the same strength of tacrolimus in a case of giant papillary conjunctivitis over 3 months, and they reported resolution of papillae within 2 weeks' time. This was a monotherapy. Kirka et al. Has tried a still lower strength, 0.005% tacrolimus in steroid refractory VKC, and has reported significant clinical improvement in the disease. With the higher strength, successful clinical outcomes have been reported in refractory ocular allergy. To conclude, tacrolimus 0.03% could prove as effective, safe, and well tolerated as monotherapy in pediatric patients with VKC. So its early inclusion in the treatment armamentarium can obviate the use of multiple drugs and can prevent blinding sequelae. Thank you.